So, welcome to our webinar. I see that some people are still joining, so while they join, I would like to welcome you and thank you for taking the time this morning to be with us and to see and listen to some of our results and also maybe share your experiences and thoughts about our work. My name is Stefan Mandić-Rajčević and I'm the moderator for the next hour. I represent one of the partners, the Media Education Center from Belgrade, Serbia, and I'm a researcher at the Institute of Social Medicine, Faculty of Medicine at the University of Belgrade. So, Action for Health and Equity, Addressing Medical Desert is a project co-funded by the Health Program of the European Union, aiming to reduce health inequalities by addressing the challenge of medical deserts and medical desertification in Europe. Before we start with our activities today, I would like to mention some of the house rules. If you have any questions during the webinar, please type your question in the Q&A section in Zoom, and we will monitor this section and your question will be asked. If you wish to speak, feel free to raise your hand. We are really happy if you want to participate in the discussion, so we welcome this kind of interaction. You have probably noticed this webinar is being recorded. We will try to share the link to the recording soon after the end of the webinar. So just to warm us up, Pearl, if I can ask you to share the first question and the access to Slido. We will try to welcome any kind of interaction using the Slido platform. Slido helps you answer some of the questions that we will have, and we can see all the answers together and we can discuss them. If you click on the link that you have in the chat box, you will be able to access the first question, and it's relatively easy. The question is, where are you joining us from? You can also scan using the QR code that you see on your screen. So according to the word cloud, it seems that a lot of people are joining us from the Netherlands, Belgium, Italy, Serbia, UK, Moldova, Romania, Austria. Let's wait for some more participants. Who did we get? Germany. We will be using Slido a few more times during the webinar, so please be ready to use it. It's the same link and you will see another question when the time comes. So Hungary, again, Italy, Romania, Netherlands, Hungary, Belgium, Poland, Czech Republic, very nice. Also, it's good to see that the system is working. So, our keynote speech is done by Kasia from the Directorate-General for Health and Food and Safety of the European Commission. Kasia is the policy officer in the unit in charge of performance of national health system in the Directorate-General. She works on access to healthcare workforce, and contributes to the unit's work on the European semester and knowledge building on health systems for Luxembourg and Spain. Kasia, thank you very much for being today with us, and I welcome you to give your keynote speech.
Thank you very much, Stefan, and very good morning to everyone. It's my great pleasure to welcome all the participants of this webinar. I'm happy to see that we are quite a few. We were hoping for more, but yeah, let's hope that we can distribute the results of this very precious work wide in Europe, and I will be very happy to do it with colleagues from other services in the Commission, because they clearly expressed interest in what you are doing. I was reflecting what new I could say today about challenges the healthcare professionals are facing, and it's challenging in itself because A lot, if not everything, has already been said about these challenges in these recent times. We have a critical problem of shortages of healthcare professionals, which was very much exacerbated by the pandemic. And we are not only facing a serious challenge of shortages, but we also see a decline of healthcare professionals, compounded by the problem of the unequal distribution of staff across the territories. The WHO report, which on healthcare workforce, which just has been published this week, stressed very rightly that it's time for action now. And I'm very happy to see this specific action on the ground and to see the first result of this very important project. And as Stefan mentioned, this is one of the projects in the cluster supported by the third health program. And all of them are very, very important, very difficult, because they really touch upon very challenging issues. So I think it's very, very important to share these results and to create the space for the discussion on challenges you see on the ground. The WHO in its report is calling for actions in 10 priority areas, and medical deserts were identified as one of them. So we are very timely with this very interesting work. It's really good to see that we are well on track, and I welcome this very important piece of work. Increasing staffing levels in health systems is necessary, but it's not sufficient in itself. Yeah, this is what we all realize. We need measures to improve the match between the supply and the demand, with the benefit for the underserved areas. Some stakeholders recently proposed that the Commission come up with some staffing benchmarks requirements, for minimum benchmark requirements for member states. And yes, we believe this is an interesting idea, but because benchmarks can indeed motivate a positive change. But we believe also that the journey matter even more than a goal. This is why it's very important to create the space for the discussion on policy solutions to sometimes very sensitive problems, like the retention of health workers, attracting them to the more to the less attracting areas, or helping them to adapt to deal with new tasks and new roles. And I think it's very good to see the interest from colleagues working in other policy areas, like, for example, our colleagues working on agriculture and rural policies, because indeed problems of medical deserts call for a coordinated response, for collaboration of actors from various sectors. We all realize that more structural reforms are necessary to boost the number of professionals in medical deserts. There is a need to have a more comprehensive view at regulation, at incentives, at telemedicine, and their implications for more equal distribution of healthcare professionals. We all know that financial incentives themselves may not be a decisive factor. Proximity to family, attractiveness of living conditions to establish a practice, employment, education opportunities for the family members of healthcare professionals may determine even more the choice of physicians or nurses to about their location. This is where other policies actually can help us, whether these policies are about improving attractiveness of rural areas, or policies addressing the demographic change or the brain drain. So we welcome very much, yes, colleagues who work on other policy areas than health in this webinar. The mismatch of And regional disparities persist despite the rollout of many incentives and other measures. This is why we need to give more attention to the evaluation of policies which are proposed, which are rolling out. And this is where this project and other projects of our cluster play an important role. We need this more critical look at the developed policies. This project is very important also to create the space for collaboration and for a dialogue, including healthcare professionals, social partners, and as I already said, policy stakeholders working on other areas. And I know it's very challenging to create such a space to attract the others. So I thank you very much for your efforts, Azel and the whole team. And this work is really very precious for us. On our side, we are going to continue to support the work on workforce. As you may know, we are pretty soon putting in place the joint action on healthcare workforce forecasting and planning, and of course we need to create a certain platform collaboration with you and other projects from the cluster as well, because yes, we need to reflect on how to make it right, make the tools of forecasting right, taking into account the regional mismatches in the distribution of workforce. We also try to contribute to the efforts on realigning skills of healthcare professionals. In July this year, the Pact for Skills, Partnership and Healthcare has just started its work, and they will come up with the skills strategy and other interesting, important activities. We are also assessing calls, projects submitted by professional associations under the call for proposal for training projects under the EU for healthcare. So a lot is happening. We are very active also on policy steering. So as you may know, the semester is actually the governance mechanism which we use very much to encourage member states to improve the situation of healthcare professionals. In 2020 and 22, a combined total of 18 member states received a country-specific recommendation in this area. So yes, there is a lot of happening, there is a lot ahead of us, but now I would suggest we go to the most interesting part of the webinar, and I hope that yes, we will have a very good and interesting, inspiring discussion. Thank you, and then I pass the floor to Stefan.
Thank you, Kasia, for a very nice keynote and very great introduction for what we are about to present. So before going to our next presentation, I would like to ask Pearl to show our next question that you can answer on Slido, and that consider this an introduction to the next presentation. So what is the first word or association that comes to mind when you think about the medical desert? You can connect to Slido using the link in the chat. We will give you a minute to think about your associations. So a lot of the answers focus on unmet medical needs, the loss of doctors, lack of health services, remote healthcare, vulnerable populations, and I see poverty, isolation, underserved areas, again, the lack of health workforce, insufficient doctors, low doctors or nurses, similar answers. Long distances is true. Low quality, it's the first answer that focuses on quality. Again, insufficient doctors, so unmet medical needs. It seems based on these answers that there are many faces or definitions of what a medical desert could look like, or what the characteristics of medical desert would be. This is why our next speaker and our next talk is about the definition and methodology of medical deserts. And our head team members will present our research and findings. I would like to introduce our team member from Romania, Dana, who is a medical doctor holding a PhD in public health and the executive president of the Romania-based Center for Health Policies and Services, one of our head partner organizations. In the HEAD project, Dana is leading the research component at the partnership level. So Dana, the floor is yours.
Thank you, Stephen. Good morning, colleagues, friends, everyone. We developed the research methodology considering what our policymakers need to counteract medical deserts. Evidence, in-depth knowledge, including the views of professionals, of health professionals, patients and communities. Therefore, the project devoted significant time to understand medical desertification and its root causes through a logical approach, investigate, define, and measure medical deserts and validate the findings. We started with the literature review, which included over 100 scientific articles, international, national, even the gray literature. And this allows us to draft a working definition of the medical deserts, but also to substantiate our conceptual framework, the research questions and hypotheses. The literature review unveiled as well the complex research we had to undertake at country level to define, identify, and measure desertification. So for the national research, each partner country looked at the medical deserts from a multi-dimensional perspective. A normative approach, a relative or comparative one, and the consensual one. For the normative approach, we analyzed the national policies to classify the medical deserts against the existing norms and standards. From the relative comparative perspective, we identified the geographical areas, the municipalities, most of them rural ones, with a significant deficit of health services compared to the national average. For that, we collected and analyzed quantitative data on the distribution of healthcare services and on the health workforce density, mainly the primary healthcare providers as the gatekeepers of the system. Based on these findings, we selected the areas labeled as medical desert to study them in depth through what we call the consensual approach, consisting of in-depth interviews with a large range of local stakeholders, not only to validate our previous findings, but also to gather additional knowledge on the root causes and also some grassroots solutions on how to counteract deserts and desertification. These are our case studies you will hear about later on. A web-based survey and interviews with national stakeholders completed our research. Based on these findings, we validated and improved our working definition of the medical deserts. And you can see our definition on the screen. Medical deserts imply the inability of a given population or population group to access health services, or the state of isolation when it comes to receiving health services, based on 3 dimensions, actually 3 categories of quantitative and qualitative barriers, interconnected and dependent on each other in varying degrees and modalities. These are the physical, the social, and the policy-related barriers. Physical access barriers include the limited access to the first-line services, distance to primary care or time to reach the closest health facility, as road infrastructure, transportation differ from country to country. Social barriers are a social construct, a very complex approach, include acceptability, affordability, services that are not covered by health insurance, or the high cost of health services, and including the informal payments and the extra billing, but also the cultural sensitivity and the context appropriateness of the offered care. Policy barriers are well known, and they were previously mentioned. They include the workforce shortage, the uneven distribution across the country, the concentration of specialized care in big cities, the long waiting time to reach specialized care, the lack of innovative solutions like telemedicine, digitalization, or the roles and tasks of different health professionals, categories of health professionals, sometimes frozen in time. Well, after we studied, defined, and measured the medical desertification, we validated our findings through focus group discussions with the community members, with the local authorities who have responsibilities in organizing the healthcare delivery, and of course with the health professionals. What we are doing now is to build consensus around the causes and solutions we found, and to facilitate a genuine policy dialogue, as there are feasible short-term measures beyond the long-term needed strategies. It's interesting, we have country findings. They are all in the country reports, and now we are looking to a cross-country analysis of our findings. Thank you. I'm ready for questions if there are any.
Thank you, Dana, for your presentation, and thank you also for respecting the time and giving the time for our participants if they have any questions. For the time being, I don't see any active questions, so my proposal is that we go also to the next presentation showing country findings in Italy, Moldova, Serbia, Romania, and then we can open the discussion. Our two head team members will present our research findings, which is Dana and now Aysel. Aysel is our head project coordinator at VEMUS Foundation, the lead partner organization for the AHEAD partnership. And Aysel, feel free to start with your presentation.
Perfect. Thank you very much, Stefan, for the introduction. And it is indeed my pleasure to present to all of you the extensive research, as Dana mentioned earlier, gave you an overview of what we have been doing in each country. So I'm here to do sort of a bird's eye overview in a quite limited time, but I hope to give you the real flavor of the most interesting things that I think I would like to share with you all on what the countries have found in their local context on medical deserts. So I already mentioned, and you can see on the slide, the countries of this consortium and where the case studies of this medical deserts have been conducted. So I will follow through the alphabetical order of the countries, but so it'll be Italy, Moldova, Netherlands, Romania, and Serbia. So on the next slide, we can start with Italy as the first country that I would like to share the findings from about. So in Italy, it is in all the demographic and health indicators, they are marked regional differences between male and female populations, and also reflecting the economic and the social imbalance between the north and the south of the region of the country. In the 2014 and 2020 programmatic period, Italy put in place a new integrated policy called the National Strategy for Inner Areas, some of which you can also see reflected on the slide here. These areas are rural areas that are characterized by their distance from the main services, including also education and healthcare services. The policy on these inner areas applies to every region and the macro area in Italy, and it also aims to contribute to the country's economic and the social recovery, creating jobs, fostering social inclusion, and reversing the demographic decline in these areas as well, both in terms of the population size and the age profile. These areas make up around 53% of the Italian municipalities, covering 61% of the national territory and being home to around 23% of the Italian population. So quite a big, significant proportion. Within the definition of the inner areas, there's also marked differences, of course, but with the peripheral and the ultra-peripheral areas are given the top priority for the policy intervention. Of course, these are linked to medical deserts, so to speak, and the definition, which was found to be still a different or unknown concept in the Italian context. In the research conducted by our Italian partner, Cittadina Iniziativa, we found several common patterns and trends that implicitly refer to this medical desertification, which are that geography is a key determinant when it comes to medical deserts. This is also linked with a distance and the rurality of the area, which also represents barriers of cost, time, and inconvenience for patients in access to primary healthcare and prevention. This is worsened by the shortages of health personnel, and there is also territorial assistance challenges and to medical facilities, especially in remote areas. It's also observed in the national context that there is an issue of passive mobility. So both the outside the province and outside the region. So, for example, the wealthy citizens prefer to migrate or move to or use the facilities of the northern Italy, for example, from the south, so to speak. Also on the map, you can see two specific case studies that we looked into in the Italian context. So one in Campania and one in Sicily. So I will start with giving you a bit of an overview of the Piedimonte Matisi in Campania as the key issues that were identified in this locality were that there is a serious shortage of professional assistance, specifically with the primary care, especially GPs and pediatricians of key concern, but there was also the challenges with obstetricians, surgeons, internists, oncologists, and nephrologists as well. Another key issue in this area is there's a shortage of services for transportation for people with disabilities and those that are using what is called the integrated home care service. Because of the shortage of staff and also the special vehicle emergency response teams. And also there's unacceptable, which is unacceptable for the users in mountainous municipalities. So in fact, it actually, it can take as long as 70 minutes to reach the municipalities of Alto Maltese, the closest facility there, for the emergency service as well, which is quite a long time. In Sicily, we have the case study in Avola and Noto, and where the critical issues that were emerged that, well, in this area, there is two main hospitals in Noto and Avola that do not meet the needs of the area in terms of the guaranteed times for emergency treatment and also in terms of the department's presence. Among other things, they are unable to function autonomously in case of emergency and to guarantee adequate service. There are, of course, also shortages of the medical professionals, both for GPs and also some of the specialists that were mentioned before, and again, long waiting times to get a specialist visit. And it's important to note that it's also the dynamic from a perspective of timing and tourism. So these problems reach the peak during the summer period when the catchment area increases considerably due to a large influx of tourists as well. So I want to then move on to Moldova as our next country to present you some of the findings on the next slide. And so as with the other countries, with the exception of the Netherlands, Moldova is experiencing a decreasing working population due to outmigration and the demographics. There's also increasing urbanization, and urban areas are viewed to be far more attractive for young professionals, leading to a medical desertification again in the rural areas. We have 3 case studies in Moldova in localities called Criuneli, Telenesti, and Pințeti, which are, and there are some similar findings among them that there are differences in access to care, which is limited by the availability of the health professional. There is also insufficient young professionals that opt to work in rural and remote areas, which is linked to the attractiveness of the profession and the locality. And it is a sort of on the national level, it's also a problem of the salaries and the income in the public sector of health professionals as well. In all 3 locations, it was also noted that there are long distances and waiting times for specialist care as well. Another challenge in Romania, specifically linked to medical deserts, is the roads and the infrastructure, which is of a key concern. There are low quality of roads and low levels of development of infrastructure in the rural areas for the healthcare providers as well. And it was noted that in Moldova, its access can be better evaluated, not just by distance, so 1 kilometer from home to the GP, but also the time spent for accessing the healthcare service. When we spoke with the stakeholders, we found some of the local level respondents that they mentioned it's time to think about a post-diploma regulatory policy or retention measure to be able to be implemented to address this geographical distribution across the country. And there is an urgent need to increase salaries to mitigate the deserts. And with some respondents on a primary healthcare level also mentioned that the involvement of the local authority is needed in order to increase access to healthcare for the population in rural areas. On the next slide, I want to dive a little bit more into the Netherlands. Yes, thank you. In the west of the region, Netherlands is known to have one of the best healthcare systems in the EU, but there are challenges, of course, still with availability of GPs, particularly, which is worsening, and but it's still better than other countries in the region. The problems that are caused, there are problems caused by the GP shortages, and it is perceived to be increasingly serious, and most affected regions and the challenges are well known in the Dutch context. When speaking with our stakeholders, we learned that, well, the term medical desert does not appeal too much to the survey respondents specifically. It is termed, to quote, vague, trendy, and too heavy for the situation of the Dutch. And secondly, the perceived level or the seriousness of the medical desertification is relatively low. You can see also on here, we had our case study area in the Netherlands as Hollandse Kroon, which is in the northern part of the country, where the population is increasing slightly, but still increasing, but the GP presence is decreasing, which also poses extra problems. Some interesting factors that specifically relate to the Holland's-Kroon availability, access to healthcare is our medical deserts phenomenon. It's also given on the slide. So there's issues with GP, travel distances, waiting times, and others. And there's a specific population that could be identified to be affected, namely the elderly, patients with chronic illnesses, those in need of emergency care, migrant workers, those with limited digital skills, mobility issues, and care avoiders. There have been some reflections or findings that some respondents refer to the social cohesion in the area that actually helps counteract these challenges, at least to some extent, which is some of the strength of the area. And it is, let's say, sort of a false perception or the fiction, so to speak, of the area, according also to the Holland-Kroon inhabitants, that it's an attractive area, actually. And the strength is that people are in this community are resilient, they're innovative, they're proud to be there as well, and they show cohesion. Interestingly, the region is also experiencing a recent, but still mild, but an influx of newcomers with housing developments underway. And this has not yet led to an increased attractiveness for service provisions, but yet to be seen. We also observed in this case study an opportunity, so to speak, well-being on prescription, which is a successful intervention by the social care providers to help people with a mild psychological symptoms and sort of keep them away from GP practices. So that was a nice, good intervention, successful intervention. But it is also, I guess, a remarkable finding that so to quote from some of our respondents, every organization is implementing their own digital strategy, resulting in incompatibility and interoperability of tools, perhaps also of the digital tools. Some of the things, and I think this is also a bit of a cross-cutting in other settings as well, that respondents point to duty bearers at several levels not taking their responsibility. So there is a municipality involved, health insurers, health inspectorate, care authorities, and sort of pointing at each other in a way. There's numerous complaints that have been filed, but with little effect, as findings from the stakeholders that we interviewed. So in the next slide, I would like to move on to the Romanian case study, whereby just to tell you a bit more about the overall context, as with the others, there is also decline in the population, but the rural population is the highest, together with a Slovak Republic comparative with other countries. There's also a decline in the number of GPs, particularly in the rural areas. On average, the percentage of GPs in the country is also below the EU average, and there are persistent disparities in access to care due to an imbalanced distribution of health workforce across the country. And access challenges are exacerbated by the poor transport infrastructure. Another thing to mention is that Romania actually trains sufficient number of medical professionals, but many migrate to other countries, which is also a well-known phenomenon. The government has taken some positive steps to address this. Things to mention that there's been a significant salary increase in 2018, and also the development of the recent Human Resources for Health Strategic Plan 2022 to 2030, which is also a big important milestone for mitigation. In Romania, you can see also on the maps, we have two case studies that fell into the definition of medical deserts. There is one in Polesti and Sfantu Gheorghe, which are both the rural municipalities, as you can see on the map. I want to start telling you a bit about Polesti first, which is a commune located in the northwestern part of Vâlcea County in the mountainous area. So this is a medical desert, as also the locality has no permanent GPs, However, there are 2 GPs from a nearby locality, which is approximately 6 kilometers away, that come to Polesti 4 days a week. So 2 GPs, so 2 days for each GP in a space that's provided by the town hall. As far as the emergencies and the different medical specializations are concerned, closest hospital is in Vidra, which is 25 kilometers away for easy cases, so to speak, and in Farcasanu, which is around 60 kilometers away for a rather severe cases for specializations or specializations that are not to be found in Vidra. So when speaking with the stakeholders, there were some findings that, well, despite being far from the current standards indicated as a proper healthcare, the stakeholders do not label their locality as a medical desert, simply because the current status is better than it used to be. And until 2003, it was Polesti was part of another locality. And after the separations, the locals' access to GPs have improved. Therefore, they don't need to be forced to come to the practice in the nearby facility of the Tulnisi, and instead the 2 GPs from there come to Polesti. So, and additionally, this location is also seen to be far better off than other communities in the area as well. And for the second case study, which is the Svanto Georgium, which is a commune situated in a Danube Delta and is reached only by water. So you can imagine how it could be a medical desert in that sense. But it only takes about 90 minutes to get from Tulsi to Svanto Georgium using a high-speed boat. So it is a medical desert because there is no GP in a locality as well, but there is a community nurse and a GP from a neighboring locality that comes once a week, partially to make up for the lack of access to constant access to the primary care. The other constant healthcare related service are the pharmacy and a high-speed boat used as an ambulance, which is as a result of the efforts put into by the town hall in order to cut in half the necessary time to get the patients from the hospital, namely in the also Tulsia region. When it comes to stakeholder consultations, there was actually 3 distinct discourses from this community about the medical desert as a location. Number 1 is that it is a medical desert. Secondly, there's a second discourse was that access to medical services is problematic, but it's not quite a medical desert because there is a community nurse. And number 3, the discourse was that it is not a medical desert because the situation is better than it used to be approximately 50 years ago. And I guess one thing to note, there was sort of a level of stoicism, so to speak, that was observed from the people, sort of to expect that if you are to live in a Danube Delta, there is not much to be done. That is inevitable that there will be a certain level of isolation. And so the expectations of also the receivers of the care was quite different compared to I guess, other case studies. So to move on to the Serbian context, again, to start with some contextual factors for this candidate country for the EU, is that there is also the decreasing population in most regions. Population is getting older, and there's again big differences between the rural and urban areas as well. In this context, we paid attention to 3 areas, as you can see also on the map: the Makvanski, the Okrug, or the county, the Podunavski county, and the Srednje Banatski county as well. In these localities, and it is also similar to other cases, there was a limited availability of the healthcare workers, particularly general practitioners, but also pediatrics and obstetrics and gynecologists. To share some of their reflections from the stakeholders at the central level, well, the discrepancies between the perceptions from stakeholders on the central level and the local level. Central level stakeholders hardly believe that there are many medical deserts at the district and the municipality level, while some stakeholders at the local level recognize a frequent lack of access to healthcare services due to an inappropriate skill mix of the healthcare facilities at the local level. Secondly, it's important to note that there is also, when it comes to types of services, the outpatient and inpatient services, it was important, the importance of accessibility and availability seems to weigh of equal weight for our stakeholders in the Serbian context as well, when it comes to the access to healthcare. So conscious of time, and to move on to the common themes that I think, some of the emerging common themes that we're still validating and we're still sort of looking into, just to sort of show you some of cross-cutting things, and to summarize some of the diverse contexts. There is, one thing is, there's a low familiarity with the term medical desert, but the understanding of the concept and the problem is actually there. So it's a new term, but the concept is familiar. Also, in our case studies, you would see that, well, they fell within the characteristics of being sort of rural, remote areas, often in mountains, behind rivers, distances in large centers, or big healthcare facilities, and experiencing seasonal problems, either to weather or tourists as well, and often with decreasing or low population densities. GPs density is as well being the primary healthcare accessibility is one of the most important factors, but also it's important to think about the access to facility can be measured by time or distance. Of course, secondary care hospitals are also mentioned specifically in our context, but it is secondary indeed in that case, with some specialists being of particular importance also when it comes to access care that I mentioned, which are oncologists, gynecologists, and others. Emergency care is also quite important, especially it was mentioned frequently in the Romanian and in Italian context. But again, a GP sort of always sort of had priority as well. And last thing on there, I wanted, there was a theme that there was insufficient mitigation, solution, and strategies that are available both on the national and the local level. There's sort of no clear ownership, so to speak, for the problems, or then therefore also solutions, which is also where we as a head hope stepping in sort of to conduct our research, to come up, to contribute to this solution finding and ownership through our consensus building, as was mentioned by Dana as well. And on a last slide, just sort of a first glance of some of the root causes that worthwhile mentioning is that, well, things are sort of are also getting difficult, or are difficult by the increased needs, the healthcare needs. As we know, we are experiencing sort of new crises such as aging population, aging healthcare workforce as well. There is higher administrative burden asked from the GPs as well. They tend to, which takes away from their time per patient, lack of preventative strategies in also such as lifestyle medicine, low social livelihood security, sort of increases the need of the population and therefore the needs for the healthcare. There is also supply of the healthcare workers that related to things like retiring GPs or other healthcare workers. Limited number of young professionals that want to become GPs, or also sort of those that move to larger centers, not returning from their hometown, so to speak, or from the institutions that sort of they were prior to that to do their specialization for the GP and others. So, and general context, and I think important to note the challenges that of infrastructure, facilities, maintenance of roads, so cultural or educational career opportunities for rural in rural or small cities, lack of financial incentives, image of professions, bad working conditions in hospitals, and other things that we heard a lot about that got worse during COVID, such as stress, exhaustion, burnout, and others. Concentration of healthcare services in sort of bigger centers, so to speak, and which I think highlights sort of both what Kasia has said and was also introduced by Dana, that there's a well, increasing staff levels are critical, but it's not all. There is also a need to have sort of a more holistic and intersectoral approach to really address the root causes of these medical deserts phenomenon, and the sort of and how it sort of can be defined or looked at in all the different and varying contexts we have seen. So with that, I want to conclude my presentation. I hope this gave you an overview, a high-level bird's-eye view of the extensive research that we've been doing in this consortium. And yes, there is for a lot more on our website as well, so you can check it out. Thank you.
Thank you very much, Aysel, for this beautiful presentation and for an overview of the findings, some conclusions and some open questions. So I would like now to maybe move to some questions that we have received, and feel free still to ask questions in the Q&A section of Zoom. There is a question. Have you defined some quantitative indicators that can be used across different European countries that can be used to define and measure medical deserts? And then there is a follow-up question: what kind of input data are covered by the index? So I would like to give the floor for just a few minutes. Mind the time, please, because it's already 11:24, which is good. It means that we have some interesting data to share. But mind the time, Dana, if you can try to answer this question. And thank you very much.
Thank you, Stephen. Well, yes, we consider this. We plan to look into the spatial accessibility of the population weighted by age, because as we know, the needs of the children and elderly differ and are higher, the needs for healthcare services. And we consider the access to a primary healthcare physician, a pharmacy, and the nearest hospital. And also we included into the index calculation the distance. All these were validated with our stakeholders in the quantitative research and also in the qualitative research, in the case studies presented by Aysel. So we have now a way of measuring the medical deserts or municipalities we consider medical deserts or at risk of desertification against our national norms and standards, like the number of population per GP, per family doctor, for example, to make sure that people registered with the GP receive quality care, quality services. It's a complex index, and we are fine-tuning it now for what we call the medical desert diagnostic tool, to develop the maps of municipalities which are medical deserts or at risk of desertification. All this will be then included into the visual way of looking to the medical deserts, the maps. Aysel presented you some of them, but the work is still in progress from this perspective. It's a complex index, and well, it's not easy. It's not necessarily tested in all of our project countries, just because access to data was uneven. Data granularity and access to data is a problem. But we tested it at least in 2 of our countries, Netherlands and Romania, and we are ready to share it within the MDDT, the medical desert diagnosis tool. And I'm pretty sure that with reliable data sets on population, on group age, on the health service provision, on distances, it will be possible to be used, I think, in a variety of EU countries.
Thank you.
Answer your question, Katarzyna?
It seems that Katarzyna is satisfied with the answer. I ask also the other participants if you have a follow-up question, or if your question has not been answered in a satisfactory way, or you would like more details, please contact us through our website, through our contact information, social media, email address, any kind of, we are really happy to discuss this with you. We have 2 more questions that maybe we can try to answer. So there is one from Thomas de Jong. Based on your research, is it possible to identify a factor that seems to be more prevalent in causing medical deserts to exist, or are the causes always very complex? And I can also try to answer looking at the cross-country results that we have done, analyzing the collected data. There are some factors that repeat among countries. These factors are mostly related to aging of the population, aging of the health workforce, going into retirement, and not having enough replacement for those that are going to retire. Some other common themes are not the unattractiveness of the places where medical deserts show up, or where there is medical desertification. Again, each country has their own context, so there are many other phases of medical deserts, but these are some of the factors that are common. I don't know if anyone wants to add something to this. I try to be short with the answer, or Thomas, again, if there is a follow-up question, if you want to contact us, feel free. We are really happy to discuss this with you. And there is another interesting question from Stan Beneke. Have you considered medical education in general, and whether some modifications of content is needed? For instance, more collaboration with non-medical professions. Again, I can answer shortly, and then if anyone wants to add, in our research and looking across the countries that participated, you can see this theme of medical education as very important. And you can see the theme of maybe adapting medical education to the rural medicine, let's say it in this way, or a medicine practiced in a place with low resources. This might be needed, and there are some interesting how to say, proposals coming from different countries. And again, the collaboration with non-medical profession is another theme that has shown up in several countries, that other non-medical professions can be really of great support and take off some of the burden for the medical profession. Just a second, there is another question at the end that I'm seeing. Again, if someone wants to add something, or maybe in case Stan wants to contact us, feel free. We are happy to discuss this further with you. From Jaime, thank you for the very interesting report. May I know what standard criteria or the ratio and proportion of medical personnel to the population did you apply to determine medical desertification per community you studied? So I think, I don't know, Dana, if you want to answer this, or what is easier for you?
Yeah, this varied from country to country. We all included the primary health care, the family doctors, general practitioners, weighted by population, age groups. And for example, in Romania, 2,200 population per general practitioner is what the policymakers and the health insurance consider as the standard to provide the good quality care to to the population. You will see our detailed methodology. We use the threshold as under 60%. If we are looking only at the GP's ratio per population, half of the municipalities are medical deserts. So we make it, we went in depth and we used the 60% threshold, which is in the literature review recognized was, and from there, as the threshold, you know, to analyze poverty and many other social characteristics. So we, based on this, we classify the countries in the municipalities in medical deserts, areas at risk of desertification, or municipalities with enough resources to provide quality care.
Thank you for this answer, Dana, and thank you everyone for providing a very interesting presentation. I would like to thank also the participants for really actively participating and asking questions. We are at the time that we were planning to end this webinar. What I would like to invite you all is really to follow us on social media, to go to our website. You can register for our newsletter. You can find more information at our website. So we are really interested if you want to get in touch with us, if you have additional questions, if you're interested in exploring some of the topics. We had some more, let's say, discussion points, but to honor your time and dedication to this, I would like just to invite at the end if the panelists would like to say something for the end. And maybe to show what our next steps are with from our presentations, just so you know where we are heading now.
Yes, maybe I start. I would like to thank you very warmly. It was very interesting to see these results. It is indeed what we were interested in, also in the context of our work on access to healthcare, to improve the data we use to measure access to healthcare. This is actually one of the commitments in the European Pillar of Social Rights Action Plan. We need to improve this metric. So I think that this project makes a very important, interesting contribution to it. So we will be very happy to follow up. I would also like to thank for these very good questions. Actually, I'm very happy, yes, to have this question and to have this discussion around these points. Thank you very much.
Thank you, Kasia, for the time that you have given to this topic and for your contribution during this webinar. And I give the word to Aysel to walk us through the next steps for our project.
Perfect. Thank you very much, Stefan, and thank you everybody for your amazing questions. Next steps for ahead. So I think some of the most important things to mention, as Dana mentioned, we're finalizing our diagnostic tool. That's also very exciting piece of work that's going to be upcoming. So keep an eye, as already put in the chat, some of our website. We have social media accounts, and then we have the Medical Deserts Network that you can sign up for and receive regular updates of our newsletters and keep up to date of any sort of, I hope, interesting news to be shared with you. Another thing I think it is also relevant to mention, we also working on this consensus building, as also was presented by Dana, to finding these locally owned solutions and the policy options to move forward to. We have so that's also going to be policy options per country that you will be able to see some of the outputs from ahead, but also a methodology that can be replicated in other contexts and other areas on how to build consensus and how to create this shared ownership and to come up with these options that really work on the ground. And we will be also discussing these options as well, online and in person. we're planning or hosting several national policy dialogues in each of the countries ahead, but also on the European level on sort of a more holistic overview, which will be happening next year sometime. So that's in a nutshell. Thank you very much. And here's our details.
Thank you everyone for participating. I really hope you stay in touch with us, and really we are open for any additional questions. And thank you again so much for participating. Have a great day, and yeah, keep in touch.
Bye, everyone.
Bye.
Bye everyone.